Good morning, I'm Dr. Becky Lynn. I'm here with Megan Normille and Jose Eugenio-Colon, and we are representing St. Louis University and St. Mary's Hospital, and we are here today to talk about endometriosis. Do you want to say a little bit about yourselves?
Okay, so I'm a physical therapist and I primarily specialize in women's health, men's health, and pelvic floor disorders.
And I am a minimally invasive gynecologist, and I specialize in excision of endometriosis.
So today we're really going to focus on endometriosis. So Dr. Colon, why don't you tell me a little bit about what endometriosis is?
So endometriosis is a disease in which the endometrium, which is found, this the internal lining of the uterus, is actually found outside the uterus. So the most accepted theory of how endometriosis happens is that some women undergo a retrograde period in which the blood flow, instead of coming out the cervix, out the vagina, the pressure inside of the uterus builds up, and there's some spillage that goes up the uterus, out the fallopian tubes, and then that tissue deposits itself in what we call the peritoneum, which is the wallpaper of the abdomen.
I like that, the wallpaper of the abdomen. So these endometriotic implants can end up on your bowels, on your bladder, on your ovaries, and they can really cause painful sex. So that's kind of where I come in that I see a lot of patients that I end up sending to Dr. Colon and Megan as well, because they develop painful sex. So how do you treat them?
Okay, so there are medical ways to treat pelvic pain, and there are surgical ways to treat pelvic pain. We focus mainly on the surgical treatment of endometriosis. We believe that the best treatment for endometriosis is actually excision, going in laparoscopically and removing the diseased tissue and having a wide margin from the areas that you are removing the nodules. Because as we know, endometriosis is neurogenic, and it creates its own nerve endings, it creates its own pain pathways, and it's important because it actually creates its own vasculature. So then it feeds on itself after it's been in the tissue for a while, and this is how you end up having the adhesive disease, the nodules that you have, and the pain that's associated to having the endometriosis.
So what's laparoscopy, just for the viewers who may not know what that means?
So laparoscopy is commonly known as keyhole surgery. What we do is we inflate the abdomen with some CO2 gas, and we distend and create a fake cavity inside of the abdomen. So when we do that, we separate the internal anterior abdominal wall from the organs, so create that dome inside of your belly so that we can actually put a camera through your belly button, and then two access ports in the lower left corner and lower right corner of your pelvis, so that we could actually access your pelvic organs and work through it that way.
And you basically excise it and take it out and get rid of the endometriosis, right?
We do not believe in ablation of the endometriosis,
right?
Because it's been proven that ablation the disease returns faster, and the pain, the resolution of pain is not as better or as good as when you do it with excision of the endometriosis itself.
So how long would a patient expect to not have symptoms from their endometriosis after laparoscopy?
So it varies, and we tell our patients that it varies. Endometriosis is a chronic disease, is a chronic microscopic disease, which is what we tell our patients that when we go in.
Tiny.
Yeah, so when we go in and we do the surgery, we can only remove at the time of surgery the lesions that are visible to the naked eye. We basically get our laparoscope, which is our camera, close to every piece of tissue in the pelvis. We evaluate also the diaphragm, we evaluate also the bowel, and we remove and we identify any lesion wherever it's located for its removal.
What I think is fascinating about observing surgery is that the lesions can all look really different too. So some, it looked like just a little wrinkle almost in saran wrap, and it was actually a lesion. And so some look very obvious and they don't look normal, but some can look like nothing and it's actually endometriosis. So that's why your experience and training is so important.
Yeah, there have been several studies that have documented how should I say this? So there's been several studies that have talked about the appropriateness or how accurate are certain doctors in identifying endometriosis at time of laparoscopy, and the range of falsely identifying endometriosis for some physicians. I think the range of the study was between 10 and 90% about misdiagnosing endometriosis visually. And they explain that range at the doctors that miss it visually at 10% are the doctors, for example, like me and my partner, Dr. Young, which would have dedicated ourselves to just do endometriosis. So we are able, like she said, to identify all the lesions in the different aspect of their course. So that makes it a lot more efficacious for the patient to actually have their surgeries with doctors that have been trained in excision of the endometriosis itself.
Yeah. Now, because patients with endometriosis tend to have painful sex, they can also develop pelvic floor muscle spasm. And this is where Megan is, we are so fortunate to have both of you at St. Louis University, because when they develop that pelvic floor muscle spasm, that can contribute to painful sex as well. So tell me a little bit about what you do.
Yeah, so we definitely work in close relation. Sometimes we're seeing patients before surgery to hopefully get them going in the right track. What I try to explain to patients is I am certainly not curing or taking away the endometriosis. I can't do that because it really needs to be a surgical procedure, but trying to get the muscles that have spasmed in response to the endometriosis to kind of calm down and lengthen and release. And they can end up with bowel problems, they can end up with bladder problems, and then of course pain with intercourse. I think one of the challenging things with endometriosis is that you can't just look at somebody externally and kind of see that they have it. It really has to be seen in surgery. And so as a physical therapist, we're looking at their abdomen, we're looking at those pelvic muscles to try to help all of those muscles. And then if we need to see them post-op, we can continue with treatment to get them back to a good functioning level. I think one of the other hard things is that the severity of endometriosis doesn't necessarily meet the severity of pain.
Right.
And so somebody who's been told they have really severe endometriosis may not have a lot of pain, and somebody with very little endometriosis can have a lot of pain. And so from my perspective, you know, the treating of endometriosis is important, but we're still looking at it from a muscle perspective.
Yeah. And one of the things that I've just learned throughout my career in dealing with sexual pain is that if you don't look at everything, if you don't look at the pelvic floor musculature and you don't take care of the endometriosis, and if they develop bowel problems related to endometriosis and pelvic floor muscle spasm, if you only treat one of those, they don't always get better.
Right.
And so that's where I think our pelvic pain center really fits in, because we treat the whole patient. We're looking for all the different ways that endometriosis can sometimes wreak havoc on a woman's body. So we have all the elements in place for that.
Right. And I really rely on both of you, again, because of that strong hormone perspective. And so what recommendations are going to be made from a hormone perspective to potentially control endometriosis, but that it could also affect the sexual function too.
So I'm curious, what do you tell patients about the possible need for hormones post-operatively? Or do you just wait and see? Or what's your feeling on hormonally treating endometriosis?
Okay, so there are two schools of thoughts about treating endometriosis post-operatively. There's the school of thought that talks about if you go in and you excise all the lesions, then after removing all the lesions, the patient would just end up with a regular period, which is what we would like for them to have. So excision, after removing every little piece of disease, then provides that benefit that you don't necessarily have to be placed on birth control pills or Lupron or any medications if you truly understand that you've removed every piece of abnormal disease that is, again, visible. Because as we know, endometriosis can only be diagnosed by a microscope, by a pathologist. So it is unlikely that, or not unlikely, it is impossible that any physician would do a laparoscopy, would take pictures and tell you this is endometriosis. It has to be that they do the surgery, look at the disease, take a biopsy and send it to the laboratory so it can be evaluated microscopically so that you can diagnose a microscopic disease with a microscope.
So if somebody has pelvic pain and they have severe menstrual cramps, let's say they miss school or work, or they pass out from their menstrual cramps, or they have very painful, what we call deep dyspareunia, meaning that their painful sex really happens when there's penetration, it's sort of deep in their pelvis. What do you tell them about which route to go first for treatment? Do you recommend surgical? Do you recommend a trial of birth control pills or, you know, an IUD what are your thoughts on that?
So for these patients that have severe dyspareunia, a lot of the time when we do a specialized evaluation for them. So we individualize our plan of care based on the patient's needs and their goals. one of the things that we tell them is that there is some benefit, or I should say, there is a lot of benefit to sometimes for them to see pelvic floor physical therapy. And after they have started that process, then we can come and build upon the advancements that pelvic floor physical therapy has done, so that after surgery they can continue with the physical therapy and continue building up on everything that we've done.
Right. And Megan, how do you handle the other things that go along with endometriosis, like the bowel problems, constipation, bladder pain issues? How do you evaluate that and then treat it?
Yeah, so, but to your point, I think it's important to look at all of those things. I certainly couldn't just look at dyspareunia or just even look at bladder. It really has to be everything. And so we do a whole evaluation that first day, asking lots of personal questions about bowel and bladder, sexual function, and sometimes they're not ready to talk about everything on the first day. Their personal goals. You know, somebody might not want to be sexually active, and that's perfectly fine. But also lots of diagrams and pictures and showing that close relationship of the muscles and how they really do support and provide the same function to all of those structures. And then based on what we're finding, then we kind of do a treatment plan from there. If the patient is agreeable to it, we'll do an internal pelvic floor assessment. But I start oftentimes with the abdomen. I think so often when someone's in pain, and in particular kind of that lower abdominal pain, the abdomen gets really rigid and stiff, sometimes bloated. And so I can kind of build trust and get them used to even just touch by working on the abdomen first. Maybe looking at the colon or something like that too, just through the abdomen to start with.
And whenever I recommend pelvic floor physical therapy to my patients, their jaw drops. They're like, what? And I would say, yes, there's a pelvic floor physical therapist, and they do physical therapy for the vagina. Who knew? But it does exist. But I think they're a little nervous about what that entails. So when you first meet with the patient, do you just walk them through step by step what that entails, or would you like to add something to maybe more explain what it is so people aren't so afraid of it? Because it works wonders. It really does.
Yeah, well, with the internet and Google and all of those good things these days, some patients have come in with preconceived notions, right or wrong. And so I'll usually ask them, well, what did Dr. Colon or what did Dr. Lynn tell you about physical therapy, or what did you find on the internet? And some patients are ready and they sort of expect us to do that internal pelvic floor assessment. Some patients, I'll explain what we're going to do, and I always give them the option, and some say, I'm not ready to do that yet.
And by internal, you mean vaginal?
Yeah, so it is a vaginal assessment, so it's one gloved finger inserted into the vagina, but we always look at that external vaginal tissue first. And so if that tissue is really tender externally, we really don't progress past that. That external tissue has to be pain-free before we can progress past. And I tell them too, it's different than a gynecological exam. We're not using a speculum or any instrumentation. We're really looking at it from a muscle perspective.
Right. I see that so much in my patients with pelvic floor muscle spasm, that the vulva itself is just tender to touch with the Q-tip, which is another reason why it's important to treat everything together as a whole.
Yes, and sometimes patients will have low back issues or hip problems that can be contributing. So again, as a physical therapist, we're certainly screening and looking at all of that on the first visit. We certainly wouldn't want to miss something that could be contributing. So we really try to treat everything while they're there.
Right. Well, is there anything that either of you would like to add just to let people know about? The women out there who've got painful sex, terrible menstrual cramps, maybe endometriosis, which can really affect your life. Anything you want to add?
So I really encourage patients to ask questions. Google can be a good thing. I do recommend patients to your website so that they're getting good specific content. And I think there's a good questionnaire on there. You mentioned missing work, missing school, those kinds of things. So often we're told that a painful period is a normal occurrence, but just looking at the severity of that. And certainly in terms of pain with intercourse, really not letting that be your norm and delving deeper into why that could be the problem. And if someone's looking at surgery, asking questions in terms of the types of surgeries that are out there. I find 9 times out of 10 patients don't understand the difference or even know the difference between excision and ablation.
Why would they?
Exactly.
Yeah.
So encouraging people to ask those questions.
Personally, what I've actually grown very fond of recently treating a lot of patients with endometriosis is the fact that I think that we are being a lot more sensitive towards our teenage population.
Right.
So with the help, for example, of Dr. Powell, who's our pediatric gynecologist,
Fantastic.
She is fantastic. We are able to basically find all these teenagers that get their periods and have painting spells. They have severe nausea, vomiting, missing days from school.
Right.
And we our motto in our practice is basically, we tell them that killer cramps are not normal. If you have cramps or in such severe pain at the time of your periods, there has to be something that's wrong. There has to be something that we should do for them so that we can identify these patients that have this horrendous disease, this lifelong disease. And then the earlier we act on it, the better quality of life we can provide for our patients.
Right.
And it's all about making sure that they have a happy, productive life, that they don't have to incur in let's say, that they don't necessarily have to undergo IVF or assisted reproductive technology, which is cost prohibitive. Fertility for a lot of patients. So making sure that their anatomy remains normal and that we can restore their normal anatomy, it is of utmost importance for me and Dr. Young.
Absolutely.
I also wanted to mention the support group that we help sponsor. Really, we provide a location, but it's the Midwest Endometriosis Society, and they're a great group of people that are basically a peer support group, and so they've brought in different speakers, but just a good forum in person, but they also have a closed Facebook page, and it's to be of support to each other and provide good clinical representation and recommendations as well.
I think the other benefit of a support group is that, at least in my practice, women feel very alone. They think there's something wrong with them. Why do I have painful sex? Why are my cramps so bad? Everybody else is having pleasurable sex, and what's wrong with me? And I think just finding that group of women who are just like you, it's sort of relieving in a way. You're like, oh my gosh, I'm not crazy. This isn't all in my head.
Yes.
It's not in your head.
Yes.
And so the support group, I am definitely a big believer in.
So that's very important. And one of the things that I actually like is I like when the patients come into the office and they bring their partners with them. Because a lot of the time there's a lot of disbelief. Why? The media has showed us a different perspective from what actually a healthy sexual relationship is between a couple. So bringing in your partner improves those lines of communications between you and him. If it's impossible for him to sometimes understand, because this is not what he is accustomed to knowing. So coming into the office, listening to us talk, having that conversation about endometriosis, having that conversation about dyspareunia and painful sex, and then being part of that pelvic floor physical therapy, it is extremely important for the betterment of yourself.
Right. I agree 100% in that the media and just TV shows and movies show you one thing about your sex life, and that's really just fake. And so, there's a variety of normal, and when women have painful sex, it's not normal, and there are plenty of things you can do about it. And it's great news that we've assembled such a fantastic team. I'm so lucky to work with both of you. Really, it's an honor. So I just wanted to mention, while we are discussing support groups, I also have a support group. It's not specific to endometriosis, but I would say the majority of women in this support group have pelvic floor muscle spasm, which can be caused by a variety of things, not just endometriosis. But it's a closed, secret, private Facebook support group. You can't find it on the internet if you tried, thank goodness, because who wants that out there? For women who have painful sex or have never been able to have sex after they've gotten married or with their first partner, where they've really never been able to have sex. And that is very, very traumatizing to self-confidence, to your relationship, and you're not alone if that's you. There are plenty of women who have that going on, and we can connect you all. So, and then it's just helpful to hear what has worked for other women. Well, I tried this and that worked, and I tried this and that didn't work. So it's called Safe Space St. Louis, and it's just a safe space where you realize you're not alone.
Yeah, I've seen many patients say they haven't felt comfortable talking about their concerns with friends or parents or family, but they have enjoyed this truly safe space to see that they're not alone and that they're not the only person, and to truly see what has worked for some people and use some of their recommendations.
Fantastic. All right. Well, thank you for tuning in to this YouTube video. We have many videos on all things sexual, painful sex, menopause, lots of infertility and its relation to sex. So please subscribe. You can find me on Facebook at Women's Sex Health MD, or Twitter at Becky K. Lynn, or Instagram Becky Lynn MD. And if you have any questions, please drop me a comment, and I would be more than happy to get your questions answered. Anything you all want to say?
This is great. Thank you.
I just want to make sure that I emphasize this. You are not alone.
Yes.
That's it.
You are not alone. Now it's your turn to say that.
You are not alone.
Bye-bye.
Bye.